Okay, let's start.
Sure.
If it's okay. All right. So, hello everyone. Good afternoon, and welcome to all the doctors, nurses, healthcare professionals that are involved in burns all over India who have joined us today in this webinar. I think we can safely say these are really strange times for all of us during this COVID-affected world, and many of us are affected in this lockdown, not able to move at all outside of our home except buying essentials. The one thing, however, that has really come to light during this phase all over the world, I think, is as a national community, as a global community, we have all come to appreciate the role that healthcare professionals are playing in running the world. And on behalf of Urgo Medical India, I would really like to thank all the healthcare professionals here in this webinar for keeping our world running through your effort and contribution. So as a wound care company, Urgo, we are not directly involved in fighting COVID, of course, but we remain fiercely committed during this phase to continue serving you in wound and burn management, like we always have, with best-in-class solutions and support of educational initiatives and advances. So while a lot of health resources are focused now on the COVID fight, it is only fair that those of us are involved in other areas of healthcare, we continue to strive to treat patients with life-threatening burns and wounds and commit to providing the best solutions. So Urgo Medical India, quickly about our company, we were formed with the acquisition of UCare Pharmaceuticals, and I think many of you already know that we were always present in burns, both before and after the acquisition of by Urgo. And we will continue to do our best to ensure in changing times that we bring the best burn solutions to you. So today, as part of our education initiatives, we are glad to host Dr. Sanjeev Uppal, who is the President of National Academy of Burns in India, and the speaker of today's topic of primary burn management in India. Without further ado, I would like to pass over to Emilio Gallia, who is our International Medical Director and responsible for all education and training initiatives. Over to you, Emilio. Thank you very much.
Thank you very much, Pratik, and welcome everybody to this session that is going to be headed by our prestigious guest, who is Dr. Sanjeev Uppal. I would also, like Pratik, wish to thank you very much for keeping our patients safe during these very difficult times. I know firsthand. I'm an ex-clinician myself. My wife is actually working in a ward where they have patients who are positive for COVID. So we know all how difficult it is. So without further ado, I would like to introduce our esteemed speaker today, who is Dr. Sanjeev Uppal, formerly professor and head of plastic surgery at Dayanand Medical College and Hospital in Ludhiana, and currently holds the position as consultant of plastics. He is also currently the president of the National Association of Burns India, among other prestigious positions. If I have to list everything that our dear doctor did, I think we will have the whole time listing your achievements, dear doctor. But I would like to mention that he headed the teaching department at the Medical College of North India and Senate member at the Balsafarid University of Health Sciences in Punjab. Dr. Uppal was also the hosting chair at the NABICON conference, which I was very privileged to be part of, and was an extremely good experience. I thank you very much, dear doctor, for doing that conference for us, which was amazingly done. He's also author of numerous successful publications, CME presentation and events, and also a conference speaker. Before I hand the microphone over to our esteemed speaker, I would like to tell you that at the end we will be able to answer some questions. If you have any questions, please write them down in the chat option that you have at the bottom. We will obviously not have time to go through all of these questions, but we will try to get through most of them as much as possible. Thank you very much, Dr. Sanjeev Uppal.
Yeah, a very good evening to all present in today's Zoom meeting. And my introduction given by Emilio was quite amazing, and I could know a few things about myself. So that is how it is. So today we are going to discuss, am I audible to all and can be seen by all? So, hello?
Yes, I think we can see and hear you very well, Doctor.
Okay, so I will start with today's discussion. First of all, I wish you all a very, very safe and you see, in-house life for the time being. So take care of yourself, take very good care of your family, and take, of course, very good care of your patients. Be safe and let others be safe. So today the point of discussion is the Indian scenario in primary management of burns. So burns as such are very well managed in our country. Of course, there are some resource crunch at times, but as many of us have visited the overseas burn units, I think our burn units are doing amazingly good and almost 80 to 90% at par with any of the developed countries. So going with this, we need to see the primary care or primary management of burns. That means right from the occurrence of the burns till we actually either close the wound or the patient is discharged or the patient is stabilized and with the conservative treatment without any intervention or with intervention. So as such, as we had to discuss the Indian scenario, I had sent a questionnaire to many people in our country, and I'm lucky because the notice was very short. Many people responded to the questionnaire, and so that we could get a idea of what is being done in our country. So I'll go for the discussion. So you would listen to me first. You'll have to bear with me for some time, and after that we will start with the question answer session. So if you see, what are the treatment objectives in okay, I'll go for the PowerPoint and then share the things. So this is now what are the treatment options which we have in the burns management? Am I okay with these slides and all? Please let me know on the WhatsApp, Pratik.
I think we are still
Yes,
seeing.
okay.
I think we are still seeing your browser rather than the PowerPoint.
Right.
You are not seeing the PowerPoint?
We are seeing it, but there are some error boxes in between.
Yeah, you have to stop share and share the share again the PowerPoint.
How do I do that?
From the top.
Stop share. Fine.
Yeah, and
that is okay now.
And share now with your PowerPoint.
Okay. Is it okay now?
That's brilliant. Thank you.
Yeah. So what we are discussing is about the pre-hospital care. So I'm not able to move forward or backwards. I don't know. Need to say stop share and screen share with the. Okay. So these are the treatment objectives which we have in mind. That one is the prevention and treatment of shock in case of burns. Second treatment objective is the control of bacterial proliferation. And the third one is the conversion of an open wound to a closed one. There are some other important considerations are the maintaining and preserving the body function, maintain good appearance and healing within a minimum period, and mental and emotional stability of the patient and at times of the relatives. So about the pre-hospital care, as you see, what we should, once the patient approaches the hospital or the ER physician or the first contact surgeon should, if the patient is immediately brought to the emergency room, the consensus amongst all the centers is that cooling by pouring water, if it is within 5 minutes, 10 minutes or so, or otherwise there is a history is recorded that whether the patient received some cooling or by pouring water on the burned area. Then about any topical application which is not recommended at the place other than the hospital or other than a qualified physician or surgeon. And then we should record a history of any oral intake or IV fluids which needs to be inquired. And then the painkillers or antibiotics, which are antibiotics initially are not recommended by the first medical practitioner before he sends or she sends it to the hospital. Then if it is given, then we must record and we must take into consideration. Many centers are still plus minus about giving antibiotics to a burn patient or not. But at our center and many other centers, they would like to start, if the patient directly comes to the hospital, one should like to start a single antibiotic, and the cephalosporins is the antibiotic of choice at different centers. And then we need to have the patient nicely wrapped up while bringing, because once the patient is in the hospital, we must record the temperature. The rectal thermometers, if available, should be the best possibility. Then about the nature of chemical, if in case it is a acid burn or chemical burn, if it is known, then it must be recorded in the history book. Then about the voltage, if it is an electric burn, if you can ascertain whether it was high voltage or low voltage current. So this is what is being done in almost all centers in our country. Coming to the primary survey, whatever the centers in our country record during primary survey, of course the percentage of burns is recorded, total burn surface area. Then the depth of burn is recorded. Most of the centers recorded by looking at the appearance. So here comes a bit of a kind of error in judgment. Maybe once I am recording might be a different, but the percentage may not fluctuate much. So almost all the places are recording it by looking at the appearance. Punch biopsy is, all the centers said that they are not doing it. The Jackson spin prick method they are applying. The thermal imaging nowadays available, but I think not being done at any of the centers. Please correct me if somebody is doing it. Then IV dye and fluorescent, not available yet, not being done. Any other thing is about the circumferential scarring and all is noted. The circumferential burns are noted, and any constriction bands or anything is noted. And general survey is done about as in done in any trauma case, about any other associated injury. Then there's a record of any history of any comorbid condition. If the patient is conscious or if the relatives are accompanying, we must record about hypertension, diabetes, and any of the tuberculosis or any other comorbid condition if he or she has. And if she or he has the condition, we must record the kind of medicines being taken by the patient. Then the next question was whether intubation or tracheostomy is done so quickly or lately, or what are the various criteria which the centers follow. So one thing which everybody agreed, that patients with diagnosed inhalation injury, that means a person has been burning for some time in a closed space. Number two, he has been burning or there was chemical factories, or there is a lot of wood lying here and there, so that we suspect the cyanide and carbon monoxide poisoning. And inhalation injury means we can just look at the lips and just ask the patient to open the mouth if he is conscious, and look at the soot and other kind of features of the burns in the oral cavity. Then if the patient is in respiratory distress or stridor, I think most of the centers say they would go in for an early intubation, because later on it may not be possible and patient might have to be undertaken into the OT and tracheostomy done. Then the patients not responding to head elevation. One of the very popular centers said that they just raise the head and see if the patient can start getting better. And if he's not responding, then they go in for intubation. Then of course the suspected case of inhalation injury like the facial or laryngeal edema is very clear. And then the falling saturation levels in the ER or at the time of transfer to the ward or the burns unit. And of course, unconscious patients, everybody would like to intubate. Now coming to the IV lines, in the peripheral lines are put in, and many centers say that they usually wait for CVP lines or arterial lines, and they start with 2 IV lines if possible. But what are the criteria for CVP lines? If it is almost less than 50% burn, or maybe at some centers say that if it is more than 50%, with both the upper limbs and both the lower limbs are burned badly, and so they don't have any access to the peripheral vessels. Then inability to secure, of course, peripheral lines, and the burns involving upper and lower limbs. And if it is more than 50% burn, with venous cut down, if possible, should be done. But nowadays, with the availability of anesthesia people and availability of intensivists in all major centers, these CVP lines are put in the emergency only. So the venous cut down has gone down, which is not a very welcome development, but then its preference is with the surgeons and ER physicians as such. If there is a persistent hypotension with the need of continuous monitoring, then CVP is the only answer. Arterial lines, sometimes they are put if the patient is in septic shock and monitoring is not possible with only CVP lines. And we need to have, we need to send quickly, we need to keep on sending ABGs. So rather than that, we should go in for an arterial line. Then about the survey which I conducted about the choice of painkillers or sedation given to the patient, because pain is one thing which is second degree burn. Patient might, if the pain is not controlled, he will go into hypotension, and even it can contribute towards the mortality. So it is, the center said that they start the painkiller and a step ladder fashion. It is the increase the painkiller, the sedation is increased. To start with, many of the centers would give paracetamol, and added to that is tramadol. Nowadays, because IV paracetamol is available, so it is usually started. And then they shift to, if the tramadol is unable to control, wherever the morphine is available, the morphine is given. Then few centers in Bombay, Indore and other places, they prefer to have a mixture of the painkillers, where they add ketamine, midazolam and fentanyl onto the ongoing painkiller and monitor it, of course, and increase or decrease the dose according to the pain. So tetanus prophylaxis is always given, and some centers say that if it is, patient gives a history of within 6 months, the immunization is not done. And some centers say that they would do anyway, and tet globe in major burn is added to the usual tetanus toxoid. About the major question about the fluid resuscitation. So that is the major debate. Every conference, every CME has a debate on it, and every place has a different formulas following. But most of the centers which responded to my questionnaire, they said they are following Parkland formula, of course, plus minus depending upon the CVP, depending upon the urine output, depending on the maintaining the blood pressure and all those things. There's another formula which American Burn Association consensus formula, and the Safdarjung Hospital has developed its own formula. They say that they have modified the modified Broca's formula depending upon the output, and is following mainly the modified Broca. So most of the centers follow the Parkland, but few centers follow the modified Broca formula. Then choice of fluids in the first 24 hours, there's no debate about that. Most of the centers use crystalline solutions, while some centers, they mix the colloids if the urine output is not improved in 12 hours time. And some centers, they start right away, start with the daily albumin, and 20% albumin is given daily. And then some centers say that they were not sure about, they have plans to start using the plasma. About the investigation, all routine investigations are of course sent, and along with that the swabs are taken for culture sensitivity. And then if there is a associated injury, then of course the X-ray and CT scans of those areas are done, so that we do not miss a kind of liver trauma and all. Especially in electrical burns or falls, where the patient has fallen from a pole, and we usually miss the liver injury or spine injury or anything, and then later on we are looking at that the burns are not that much, but the patient had a kind of morbidity or mortality. So one has to have a full examination of the patient, right, back and front and all the limbs and all. And of course, taking care in the electric burn patient or patients who had fall, to stabilize the cervical spine before we turn the patient around. Then about the wound toilet, most of the centers, on immediate arrival, they do it in their dressing rooms or in the ERs only. A few centers, they prefer to go in for OT. Of course, there are few dedicated centers in our country also who have exclusive burns program, and they have the OTs available for burns only. Otherwise, people would prefer to go in OT, but they will not wait for OTs to get vacated. So they go for the immediate. And about the debridement, fasciotomies and other surgical interventions, their centers were divided in opinion. Some centers say that they will go for minor debridement right in the ER only or during the kind of wound toilet, but other centers say that they would wait for some times, let the patient stabilized, let few bottles of the crystalloids go in, and then only they will do it. About the dressings, there's a many things available now, right from our own potato peel, which was in because our people were not affording, or there was an indigenous product which had been very successful. But then silver sulfadizing cream is so far being used at many centers. Silver nitrate people are not very happy to use. The nano silver gel many centers use. Then silver sulfate with the technological advance like lipid colloid dressing, which delivers the silver faster into the tissues, is being used now widely, commonly known as silver impregnated dressings. And then some people say that on first degree and second degree, they would wish to use all these things. And on third degree, if the burns are much more or third degree burns, they just want to cover it with either few people, they have been using the betadine solution for that matter. The biological dressings, the collagen dressings also have been applied on the second degree after minor debridement. And the superficial second degree burns, they say that it heals much better if the collagen dressings are used or silver dressings are used. Then some people have been using about the third degree or deep burns, the debris days dressings, the silver foam dressings, or dressings for healing the deep wounds with foam dressings to absorb the transudate as such. So coming to the fasciotomy and escharotomies, to be done, not to be done. If you decide to do it, then how they are done. Most of the centers were of the opinion that if there are circumferential burns and we have the pulse oximetry, we have the, you can judge from the nail if you can judge the circulation part, and then of course the pulses, the peripheral pulses are coming or not coming, and there is a neurological compromise, they would go on for a kind of fasciotomies. And in the case the chest is circumferentially burnt, abdomen is circumferentially burnt, patient is unable to take full breathing and the saturation is coming down, and even with the intubation sometimes it is not achieved, then the escharotomies were done, and crisscross or square, or the different patterns people have been using. And those circumferential burns of the chest and abdomen, one has to be very careful and should do the escharotomies quite early. And then electrical burns, if the edema is leading to compartment syndrome, we all can diagnose that, and we should go for very early fasciotomies and escharotomies. If we are not happy with the escharotomy or fasciotomies, then we need to take the patient to the OR and do something more extensive debridement. Then about the early excision, so everybody says that the early excision is the gold standard these days, but some very few people opined that they do not have the lot of blood available, they do not have the skin banking facilities, and the burns are excised. Many times the relatives, they do not give consent. They say, if we are spending money on this surgery, or we are say subjecting the patient to OR, and then whether our patient will survive or not. So this is a question faced by many of our surgeons. So they usually tell them that this is not a as such guaranteed procedure, but it is a life-saving procedure. And in 70-80% they say the people agree for early excision. So when to be done, there was a consensus that the excision should be done at 48 hours to 72 hours. Once the patient is stable, all the investigations are within the expected limits. Then about the total burn surface area excised varied from center to center. Some centers say that they are excising 15% to 20%, and some centers say that they are going into 30% excision. Very, very few centers say that they go beyond 30%. Then about the special preparations before we do early excision, of course, are the a lot of blood transfusion availability should be there. And if there is any contraindication, then the unstable patient, the patient is not stable, so we should not go in for early excision. That may lead to added mortality or morbidity. Then about the coverage after early excision, or what should we do? So autograft is the coverage of choice. If the patient has go up to 30-40% burn, and we can harvest or even up to 60% burn, we have the facility to have we can harvest the graft, and then expanders are available if they're mechanical expanders, or by giving cuts, some of the centers they expand the graft, or stem graft we use. So that is the best thing. But then if the skin banking facility is available, which is now available, expanding quite a number of centers now. I understand there are around 16 skin banks working in our country. So that they use the sandwich sandwich autografts with the allografts in the ratio of 1:1. So they apply a very fine or the kind of stem grafting or something like that, or expanded graft, and then put a layer of the cadaveric skin over that. Then others, they say that if they are not able to do this thing, they can go in for the dressings, which of course the most of the centers then use the silver sulfate kind of impregnated dressings, and few centers are using the collagen dressings. Then the criteria for silver dressing versus early excision. There is a line of, you can say, it is not a dispute. Of course, early excision is the procedure of choice, but some people, they say doubt or debate it that they got the good results even without early excision. So we need to believe them, because some papers have come in with quite good amount of results as such with the dressings. But then you understand that there's a very fine line of differentiation between the superficial second degree and the deep second degree. We can expect good results with superficial second degree and some of the deep second degree with silver dressing, but not in all. So we are not debating here about the early excision and silver dressing, but since this was a question, so many people said that at superficial first and second degree burns, they would like to apply dressings. The second degree deep burn, their feeling is that it might improve, or there are skip areas of deep burns and the superficial burns as such. So they would go for dressings. And with, of course, where the patient cannot be taken to the OR and people have got comorbidities, they would like to discuss with the relatives, and relatives are not very much willing to take the risk. Then the patients are given the dressings as such. So this is all what I could gather about the primary treatment. Of course, once the wounds become better with the conservative kind of management and the patient becomes better, we go in for the standard protocol without early excision is to go in for the wait for wounds to granulate, then become better, and within 2 to 3 weeks time they become, the bed is fine, and we do grafting. And during grafting, of course, the physiotherapy is introduced very early at all the centers. The psychological support is started very early at all the centers. And then the splinting of the areas of the joint is done with once the physiotherapy is carried out and the things are splinted, the hands are moved and put in splints in a way that there are not many hand contractures. Neck is another area which is put in, the neck collars are put. So all our centers have been reporting a very low number of the contractures these days. Maybe if you go by percentage, maybe 2 or 3% as compared to the previous times. Of course, which patient gets discharged and later on they do not do physiotherapy, they do not go in for splinting at home, and so they develop the contracture as such. So this is how we want to achieve things, and I'm through acknowledgements for all these people who have responded, and all other people who are involved in the burns care, all paramedics, all staff members, and all the, you see, commercial houses which provide us with the products to be used in the burns across India and across the world. So I would wish to end here so that we have ample time for discussion, and thank you very much for being with us this evening amongst the COVID. And so coming to the first point again, what are the treatment objectives? I think the prevention and treatment of shock, control of bacterial proliferation, conversion of an open wound to a closed one, and of course, other things, maintaining body function, good appearance, healing with a minimum period, and mental and emotional stability. And we should make effort so that the patient is going back to the society and become a useful citizen, and he is accepted well by the family and by the society. Thank you very much. I wish to end here, and I'll ask Emilio to start with the discussion.
Thank you very much. That was a really very interesting results of the survey that you've done, and very, very well presented. A lot of questions already coming in. The first question is, how do most people monitor fluid requirement?
Right. The fluid requirement, as I mentioned, most of the people in the country, they use the Parkland formula as the base. That is the 4 ml per percentage per kg. But of course, the urine output has been a gold standard to monitor, because at times at places, people are not able to monitor it with CVP or arterial lines. And the only thing is that the time gap between the patient once he or she gets burned and is brought to the hospital. So that is to be documented. And if you see, for the first 6 hours or 4 hours, the fluid could not be given. So we have to rush fluid by any means. And the Parkland formula, as everybody knows, says the half of the fluid should go in first 8 hours. And it has been seen that in patients who have not been given the fluid early, so the mortality is more as compared to the patients where the fluid was started by the first contact doctor at his place.
The next question is from Dr. P. Umar. What is the highest percentage we take when calculated fluid requirement?
Yes, if you go by the Parkland formula, the actual percentage is taken. And that is where we feel need for the CVP lines in place and the patient's previous history about comorbid conditions. If the patient already has a kind of cardiac condition or is a patient of heart failure, then of course we need to reduce the load. This is just an indicative formula and not a final authority as such. If the comorbid condition shares that the patient is already having a heart failure and cannot manage that much fluid, so probably we have to reduce the fluid, but we need to maintain the urine output to the desired levels.
Thank you. A question from Tobna Chamia is a question about using albumin 20% daily. Why, when, and for how long?
Yes, one of the major centers in Bombay has responded that they start with the 20% albumin in the beginning, and they use it for 7 days in progression, once every day for 7 days. Why? Because everybody knows it holds the fluid and provides the, you see, in our country, if you go in for albumin levels, most of the people, when I say most doesn't mean that everyone, most of the people would have a lower albumin level. And if you have a lower albumin level, maybe you are unable to hold the fluid, and the drugs which we are given are not carried nicely into the body, and they act less. So that is why the albumin is given. There was a debate about 10 years back whether to give albumin, whether to give colloids or not. And then the consensus at that time was that it should not be given. But then later on, it said that after 12 hours, you can be sure that the perfusion is going nicely, outputs are being maintained. So you can institute within 12 or 24 hours. So if we have a doubt that you should not give, you can hold it for 1 day or so. You have all the detailed investigations with you. If the albumin is the target is 3.5. If it is already 3.5 or 3.8 in the patient, you can hold it for time. But you need to give it because in our part of the country, like in Punjab, we institute after 48 hours, we institute a non-veg diet, and people are very happy taking 12 eggs a day, 10 eggs a day, or chicken and all those, because they are used to. But in the states where the vegetarianism is there, and you will not be able to give oral albumins, oral proteins in that much quantity or that much level you desire, then there, of course, is no choice left than to give the albumin.
Yeah, thank you very much for your answer. There is a question here. Is there anything called open dressing?
Yes, there is something called as open dressing. We cannot yeah, I tell you. The centers where they feel if it is not manageable, suppose a 90% burn with a deep second-degree burn, third-degree burn has been admitted on humanitarian grounds to the hospital. And we are, of course, the God is the final authority, but we think that the patient is not able to survive. Then, of course, the dressing is not done. The betadine paint with a kind of cover or a dome cover with a sterile sheet over it is used, number one. Number two, if the amount of percentage is less, the burns percentage is less, some centers, they go in for open dressing. They keep on applying these creams and all those things on the wounds and keep in an isolated chamber with the sterile sheet over a dome, so that some people still believe that this is a better technique, but we have no scientific study to say that the open dressing is a better technique than a closed dressing.
Thank you. There's a comment here from Dr. Umar where he suggested that antibiotics are not started on admission as the wound would be sterile, but then go for it after 5 to 7 days. Do you agree with that, or?
There has been a lot of debate. Every time there is a debate, as I mentioned, and people say that it should not be used, but going by the record of all the centers, it is being used. The antibiotics are being used. Of course, the standard thing says that once the patient is brought in after burning, he or she is sterile. But what happens in our emergency rooms, our trolleys, and the nosocomial kind of infections in the hospital? Of course, we can be careful. Our nurses, our paramedics are very careful. But starting an antibiotic, not starting an antibiotic. And the current thing, if there is later on, there's a lot of court cases, they do happen. And at that time, you have no answer that why did not you start the antibiotic. So I don't say fully 100% that it should be started. It's not my opinion. Most of the centers start with a single antibiotic, that is cephalosporin. And if the patient has already got antibiotics elsewhere and he's referred or she's referred on 3rd, 4th, 5th day to the hospital, then of course a double antibiotic has to be used. That is the consensus by all the centers.
Yeah. I think if Shakespeare would still be alive, he would change his subject to give or not to give antibiotics as prophylaxis nowadays, because it's a debate. Even when it comes to antimicrobial in dressings, that's always one of our big dilemmas. Should I start antimicrobials? Should I not start? And obviously, as much as there are pros, there are cons about prophylaxis.
It is said in intubation, in dressing, and of course antibiotics. If you are in doubt, start it.
Yeah, exactly. Thank you very much. Another question from Rajiv Kumar is, how frequently do you encounter polyuria?
Polyuria as such, right from the beginning, nowadays the centers have improved giving the fluid resuscitation very aggressively. So as such, polyuria, if it is, we are giving more fluid, number one, then the polyuria is going to occur. And the other, there has been some studies that with the vitamin C given in the early 24 hours or early 12 hours, there has been polyuria has been noticed in those cases. Of course, they say that the fluid requirement with the vitamin C has been lessened. We conducted a study at our place and we presented it in Miami conference, and now it is published that the vitamin C instituted early will of course give to rise to the polyuria. Polyuria is not usually seen. It is usually not seen, and I don't have a study where I can say that this much percentage have polyuria.
Thank you. A question from Ganapathy is, what is used in hydrotherapy on arrival? Is it just water and soap, or do you add antiseptics?
We are not using antiseptic. It is the Ringer's lactate or the normal saline solution. The bottles are available these days, and so copious irrigation of the wounds is done. If the wounds are dirty, then more, say it is that at least 5 to 10 liters of those fluids are used to wash the patient. And the patient is, the operation theater should be nicely warmed up, because there is a lot of, you see, hypothermia, chances of hypothermia. And adding antiseptics at that time, some centers, very few centers add kind of Savlon in very low percentage. But there's no documentation. We need to clean the wound, and I think normal saline and Ringer's lactate are the two solutions where we should go ahead with that.
Yes, thank you. A question from Gayatri. A second-degree patient comes to us usually after 1 or 2 days. Should I still use collagen or normal dressing or other antimicrobials?
All the choices are open for you have to decide whether the wound is deep second degree, superficial second degree, or third degree. Once you have the superficial and deep second degree burns, all the options are open. And at least we should take a skin swab and also a punch biopsy to ascertain the bacterial invasion. It has been seen in a study conducted at many centers. We are also part of that, and we published that also, that in punch biopsy, in case of septicemic patients later on, the punch biopsy bacteria in the underneath the eschar or under the deeper layers of the skin is different than what is isolated on the surface, but only in 10% cases where there was a lot of septicemia involved. So after you take the surface swabs, and preferably if you can take the punch biopsy, all the options are open. There is nothing as such which says that it is not to be done. But silver, so far silver has been supreme over the centuries. It has been used and has the least antibiotic resistance.
Thank you. Rajiv Kumar asked you if you should add diuretics with albumin.
Please repeat.
Dr. Rajiv Kumar asked if we should add diuretics with albumin.
No, diuretics are as such not to be used as such. There's no dictum that we start using diuretics in a patient of burns. If the output is fine and the CVP levels are good and you see the patient is stable, and I don't think we should start right away. If we're giving albumin, we should start with the diuretics. It is, in my view, you might have a different viewpoint, some people, and but we have not given diuretics unless until cleared by our nephrology people. So another thing which I wanted to convey is involve other specialties as early as possible. A nephrology call, a medical call, a cardiology call. So wherever these specialists are available, they should be involved in the care. And we have a dictum, and our center and many other centers say that they involve the critical care specialist very early. And every day, at least one round is taken by the critical care specialist. So let it be, we have a kind of discussion where we have 2 or 3 doctors, they do a discussion, and then only consensus, and then mention on record that 3 or 4 doctors have seen this patient. That is very important legally. These days there are a lot of litigations, and then they say there was a problem with the heart, why did not you call a cardiologist? There was a problem with the urine output, so why didn't you call a nephrologist, whether it was not available or so. So of course I'm not saying that we cannot manage those things, we can, but we should involve. And if they say they give diuretics, we are giving diuretics once the urine output falls down. And but then all the other things are to be taken care of, like hypotension and the patient's general condition.
Yeah, thank you very much. Garapati asked how many use steroids initially, especially for inhalation injury.
Yeah, you see, inhalation injury, the steroid, there has been a debate on steroid also. Some people say that it is not going to harm, 1 or 2 doses of steroids are not going to harm the patient. So if we still believe that the giving 1 shot of hydrocortisone and then repeating it after 8 hours, 6 hours, or 4 hours accordingly reduces the edema in the laryngeal part or oral cavity and all during inhalation injury on the down into the bronchial tree, it should be given. 1 or 2 doses are not going to enhance the infection as such. So, but if you go in and ask the majority of people, they say, oh, steroid has no role. But if at a center, even I have found at sometimes it acts. So 2 doses, in my view, my personal view, not a scientific view, that 2 dosage of steroid not going to harm.
There are comments from Garapati and Dr. Omar about using vitamin C, multivitamins initially. Dr. Omar said vitamin D routine must be complex, is usually used in their setting. I think you already mentioned about vitamins, but
yeah,
if you can...
vitamin C is IV vitamin C is used in our study, has been used in our study, and a lot of dose has to go. So one of the residents, is almost sitting in the burns unit to do that. So it's not very easy to give that much of vitamin C. So we also do not give in every patient. For the study part, we give to the few patients randomly. But it can be given. IV vitamin C is a good thing to reduce the amount of fluid. Hello.
Yes, I'm trying to go through some of the questions. Yeah, there is a comment here. Is there any possibility that we can run a facility through our academy so that we can get skin grafts from various skin banks in the country, so that
Sure. The academy as such is of the opinion, and of course all skin banks are readily they are formed and they are ready to send these skin grafts. We have been asking skin grafts from Bombay, and within 2 days they reach by courier. All these centers are, if they have skin available, they would surely be sending it. None of the skin banks will deny that.
Yeah. There are a few comments, obviously, about management.
Can I interrupt you? Dr. Shobha had a question about the growth hormone.
Yeah, that's what I was going to go to. There are some questions about the growth hormones and other modalities in burns.
Yes. So the growth hormone as such is a part of the body as such. You see, we all have the growth hormone, but then they say that some of the centers they are using, and some of the commercial preparations are now available, saying that's a growth hormone preparations. They are being used, and the experimental stage, or some centers have got better results with that. I personally have no experience of using growth hormone. So I think Dr. Shobha would be able to share her opinion about that.
Yeah, I think at the moment we don't have any questions. Well, one question that I always ponder about, and I face it a lot. I used to face it a lot in the clinics. I wasn't on burns, but I was in chronic wounds. Is the question that we started on before, is prophylaxis. Should I use prophylaxis? Should I not use prophylaxis? In the reality of India, I personally think that you should be using antimicrobials from the very beginning. Do you condone with this? Do you agree?
Yeah, the opinion is divided about the use of antibiotic, but since so many of us are on the show now, I think if they can respond quickly that they use it or not, genuinely, if they say, I use it.
Yeah, antimicrobials topically, I mean, as a dressing.
Yes, I use antimicrobial topically as a dressing is used.
Okay. If there's Dr. Ganapati says, I don't agree.
He doesn't agree, yeah.
Yeah,
of course, no. Dr. Ganapati is a very senior kind of burn surgeon we have, and he's very always smiling. He has one quality. I'm going to learn that how he does it. So he doesn't use it, but I'm not contesting his this thing. We do use, but some people don't use.
Yeah. What I always used as my gold standard, and I think all of you would say as well, is that the most important is evidence-based practice. Look at the evidence. Look at robust evidence, which is there's so much out there, and then apply that evidence-based practice in your health setting. This is what I have always believed. And,
yeah, about just to rejoinder to the Dr. Ganapati's query, about 20 years back or so, I was also of the opinion that you should not rightly use the antimicrobial. So we started using the paraffin gauze only, because the paraffin as such has a property where it is to some extent itself, its pH levels are antimicrobial. So we did that. We could get some success, not in all the cases. But then going by all other people, I think majority is using, and nowadays the products are available. The silver has been amazing, and in any form, dressing, creams or gel and all. And I think I personally shifted to use of antimicrobials. Though 20 years back, I started a study with only paraffins. So I think Dr. Ganapati would add to his our experience and his own options why he doesn't use it.
Yeah, there's a very good, very interesting comment from Dr. Sokha, where new evidence is available on avoiding steroids and elective intubations, as patients do well even without that intervention.
Yes. We cannot be waiting for this thing to happen, the improvement to happen. As such, whatever one says, if you feel that the saturation is dipping, patient has stridor and patient has kind of the inhalation burns, no point in waiting. Go ahead with the intubation. Later on, of course, in 2-3 days time, you can withdraw the tube. But you see the risk once there is a lot of edema and you do not have the access to intubation, we need to do the tracheostomy, and tracheostomy has much more morbidity. So if you feel that intubation will be required, do it early. That is how it goes. Dr. Ganpati in the meantime says that he is using SSD, topical or antiseptic impregnated Tule gauze. So of course that is how he has responded.
Brilliant. So basically, what you suggested in your question, if I got it right, is you suggest to play it safe, yeah?
Play it safe. Of course, if your intuition says, if your intensivist says that the patient will not require intubation, so have at least 2 opinions. Don't we cannot, as you said, the evidence-based medicine. So involve intensivist, he or you. If both of you are the same opinion that we should wait for intubation, then you should wait. But if we feel that even a dispute 50-60% or plus minus, then go for plus.
Fantastic. Are there any other comments or questions from the audience?
I think
I have one question about patients who require extensive hospitalization. How do you work with other professionals for the rehabilitation of these patients? I know it's very difficult to get them back, as you said, and even in some of the comments, to get them back to become as much as normal as possible. What are the main hurdles that you see in India, and what are we doing to make sure that these patients go back to the community?
Right. So one thing which I mentioned is the institute the physiotherapy very early, then institute the psychological support and psychotherapy even of the relatives, and then once we went for I showed you that slide twice, that the goal of our treatment is of course to get a cosmetic result as much possible. And after few surgeries, if the results are even not cosmetic, then go in for few surgeries. The appearance of the patient and the confidence in the patient. These days the people are educated, and you must have seen the latest movie where the top actress of our country wished to become a acid burn victim and acted in that film. And so that way there is a lot of awareness these days that burns is not a stigma. Even the appearance is not a stigma. The people are educated. If the one is educated, his capacity to work, I think the society somehow these days accepts.
Yeah. There's an ongoing about steroids and when to use them. There's a comment that when there is gross facial and neck edema, definitely responds to IV steroids, and use steroids at the beginning for inhalation burns.
Yes, for two or three doses of steroid are not going to say invite or make patient very much prone for infection. If you see that the steroid is going to help, even if it is not helping, giving 1 to 2 doses if there is a edema doesn't matter, because once there was no scientific evidence, and even 10-15 years back, people have been using steroids for edema and they got good results. And now because we have right and left, we can do intubation. Our residents in the ER are very much trained about that. We have the ventilator setups in our country available with everybody now, and the diagnostic things are the kind of peripheral lines or the central lines, and all those things have reduced the use of steroid as a kind of, you see, whether we are not sure it makes a difference or not. But giving 2 dosage, in my viewpoint, it's my personal view, is not going to affect the kind of bacterial load in the body.
There's a comment by Dr. Sofa Shamian who suggested to try adrenaline nebulizer in Strider.
Yes, you can do that, I think, but nebulization alone, but then you have to keep a watch on the condition of the patient.
She added with elevation and chest physio.
Yes, she feels that, as I mentioned also, head elevation and the kind of other things go on, and if the patient doesn't improve, then go for intubation. And Dr. Shobha Chmania is one of the most senior faculties in our country, and whatever she says is, as you see, is kind of order for us.
Yeah. So the last question of this interesting. I can't believe 1 hour has already passed. This was so interesting. The last question from Dr. Manju Santoj is, what is the dose and choice of steroids?
Yeah, the dose goes as at the hydrocortisone 100 milligrams stat, and then followed in 6 hours to 8 hours, or even 4 hours, another shot, the same dosage. And then beyond that, it is not continued if there is no improvement.
Thank you so very much. This was to say the least brilliant. I really enjoyed it, and I'm sure that all the colleagues really enjoyed this nice presentation and discussion. So I invite you, Dr. Sanjeev Uppal, to give your last messages, and then for Bide Pratik to close the session. Thank you very much.
So from my side, I would like to thank all the participants for the discussion, a very promising discussion which we had, and they have been very kind to put in their questions and discussion. So thank you very much, everybody. Take care of yourself, and I would advise during this period of lockdown, you should develop your hobbies or take out your hobbies, involve yourself with the family members, involve yourself with the music, involve yourself with whatever you feel like doing. So be happy, be secure, be safe, stay at home. Thank you very much.
Thank you so very much. Mr. Pratik?
Hello, thanks a lot. So really, this was a great session. I felt we were back in the symposium room of NABICON from February, Shimla.
Yeah,
and it did not feel as if there were any limitations because of digital route. So everyone was really participative. So thank you a lot for supporting this educational session that we have been part of with Dr. Uppal. Just 2 things. If there are any more pending questions or availabilities of products for our samples, please contact us at this email, as well as if some participants would like to have a certificate for attending this educational webinar from Dr. Uppal, so that we will make sure to provide in the next 2 working days.
Definitely.
And I see Dr. Ganpati's comment as well, that when can we expect the next session? The future conferences will be online. So I hope that there will be many more conferences online as well.
Dr. Ganpati has to tell us.
I hope we will also be able to see you.
Dr. Ganpati has to tell us how he keeps a smile on his face always.
Yes, so we will also support you as much as possible in these educational initiatives. And until the next time we meet, of course, we will continue to engage online. Thanks a lot again. We are really very happy with everyone's engagement. Thank you very much.
Thank you. Thank you.
Thank you very much from our side as well.